morning. I'd like to call the meeting to order. I'd start the meeting by asking everybody to introduce himself, and we'll start with Mr. Ramey.
Gary Ramey, MLA Lunenburg West. Good morning.
Good morning, Matt Wynot, MLA Hammonds Plains, Upper Sackville.
Hi, I'm Gary Burrell. I represent Colchester, Musquodoboit Valley, and today I'm here in the place of Brian Scabar, the member for Cumberland North.
Good morning and welcome. Clary McKinnon, MLA Pictou East.
Good morning, Becky Kent, MLA Cole Harbour Eastern Passage, and I'm here on behalf of Howard Epstein.
I'm Andrew Younger, Dartmouth East.
Chris Dontrema, beautiful constituency of Argyll.
Keith Bain, MLA Victoria the Lakes. I'm here filling in for Chuck Porter.
Darlene Henry, Committee Clerk.
Al Horgan, Deputy Auditor General.
Jacques Lapointe, Auditor General.
Terry Spicer, Assistant Auditor General.
Evangeline Coleman-Sad, Assistant Auditor General.
Anne McDonald, Assistant Auditor General.
Good morning and welcome everyone. I'd like to start our proceedings this morning by asking Mr. Lapointe to make a presentation. Mr. Lapointe.
Yes, thank you, Mr. Chair. Well, as you know, my spring report was tabled with the Chief Clerk in the House of Assembly last week. It was my second report in 2012 and covered audit work completed by my office in late 2011 and early part of this year. I am pleased to have the opportunity to discuss it with you today. With me today are Deputy Auditor General Alan Horgan and Assistant Auditors General Terry Spicer, Anne McDonald, and Evangeline Coleman-Sad. Anne and Evangeline were each responsible for certain chapters in the report. And I'm sure that among us we can answer any questions that you may have. Now, before we begin, I want to acknowledge the valuable work, the dedication, and the professionalism of all my staff. Their efforts make it possible for us to provide assurance to the House of Assembly on the operations of government. I also thank the many public servants in departments and agencies whose cooperation was vital to the success of our audits. There are 5 chapters in the report in addition to the introduction. We make 77 recommendations, all intended to improve departmental and agency efficiency and effectiveness. I'll briefly mention the topics covered. In Chapter 2, we follow up on the implementation status of recommendations made in our reports from 2005 to 2009. We found little progress has been made on improving overall implementation rates in spite of government commitments to do so. Chapters 3 to 5 provide the results of audits completed at boards and agencies of the Department of Health and Wellness. We found that the Addiction Services Program in the Annapolis Valley was well managed overall. Prescription drug monitoring processes should be strengthened, and infection prevention and control practices, particularly at Cape Breton Health, need to be significantly improved. We also concluded that the department needs to improve its oversight and direction of health services. The last chapter describes our audit of the activities of the Office of Public Trustee, for which we make some recommendations for improvements. Now, Mr. Chair, just before we begin, we do have one point of clarification on one of the audits, and if you don't mind, I'll ask Ms. Coleman-Sad to just make that point.
Ms. Coleman-Sad.
Thank you. Last week, one of the members asked whether we knew if Cape Breton had contacted both of the patients that had been involved with the scopes that may not have been cleaned and disinfected properly. And I just have a bit of an update on that. At the time, I said that only one of those patients had been contacted. And I have some additional information. I understand Cape Breton has made efforts to contact that second patient as well, but apparently have had a lot of difficulties in actually getting hold of the person. So I just wanted to make sure the members were aware of that.
Great, thank you very much. We'll start the questioning with Mr. Younger. You have 20 minutes.
Thank you, Mr. Chair, and I appreciate that update. I was actually going to ask you right off the top whether there was an update on that particular issue. I want to, there's a whole lot of ground here to cover, and I doubt we'll cover everything today, so I guess the departments come back later when you do your planning. There's a number of issues in here, especially in sections 3 to 5 or thereabouts, talking about the oversight of the department over the district health authorities. And one of the things that there's some comments about whether the department is meeting its legislative requirements and responsibilities, some commentary about that. And I wonder if you could just elaborate a little bit on where you see that the department is not meeting its legislative requirements to oversee the district health authorities.
Yes, and it does come up in a number of our audits, and we've made comments on this before in individual chapters in different reports, and which is why we thought we should try to clarify that a little bit in this report. It's not a simple question because of the delivery of health services in the province is in fact decentralized, and as government policy and legislation to have a delivery of services through district health authorities. But the question then becomes, where is the division of responsibilities between those authorities and the government or the department? We believe that the legislation is stated in a way, and we believe it's government policy as well, that the central role of the department has not been fully delegated to the authorities, but that in fact the department has a responsibility to ensure through the delivery of services through the authorities to Nova Scotians is fairly equivalent across the province, that appropriate services are delivered, that government policies are followed, and to make some overall decisions about delivery of services, so that the role of government becomes not just to delegate down or to provide guidelines, but to in fact monitor what services are delivered and how they're delivered, to provide not just guidelines but standards, and providing standards means making some attempt to see whether those standards are actually applied in service delivery, and then to ensure that authorities comply with those standards. So it's a more active role than we often find is the case, and these particular audits kind of are an example of some of those roles and the ways in which we feel greater action needs to be taken by government to take on that role.
Thank you. One of the areas, and I'll maybe table this because I'm going to speak to this as it works its way around. The Health Authorities Act governs, and your report talks about this, what the role of the health authorities versus the role of the department. And when we talk about the issue of infection control and even some of the things that we see in Annapolis around the addiction control, all of which sort of pointed to this, you know, who's sort of watching over things. It appears, and I'm wondering whether you looked into this, that the minister's office has split the reporting of capital and business plans, despite the fact that the Act specifically disallows that. So the one page I've tabled is the Act, which says that the business plan has to include the capital plan as well as a number of other things. And then the other is from this year's business plan for Annapolis, which says that that each health authority is required to prepare a capital plan under the Health Authorities Act. But the minister has established an alternate process and timeline for submission. And the reason I'm asking about this is because when you go through the report and you look at things like infection control and so forth, it seems that despite the District Health Authorities Act saying that the business plan and capital plan need to be together for a reason, for example, to figure out the oversight and so forth, I assume, the minister has gone outside the Act and chosen to split that. And I'm wondering whether in your audit you looked at that role.
I have to say that when we're conducting audits like this, we're looking very specifically at particular programs and even certain aspects of those programs. Okay. So the type of issue you're talking about is not one that's come up in the audits we're looking at. So we're not really competent to comment on that side of it. So we look at for instance, in the addiction services, the standards that government has set for the delivery of services, and whether they monitor whether those are actually being complied with or not. but we don't look beyond the issue that we're specifically auditing, so I don't really have a lot I can say about what
No, that's
issue
fair.
you're bringing up.
No, that's fair. I'm just trying to, that's very fair comment. I'm just trying to see where where we start with the breakdown. In terms of the oversight, you had stated last week, or your staff had stated last week, that the department is setting rules or guidelines or standards for health authorities to meet. So, for example, let's look at it in addiction control or addiction services in Annapolis, which was one of them. But then it appears that nobody is actually walking up to Annapolis and making sure that they're following those guidelines. Am I understanding that correctly?
Yes, I'd say that's a fair representation. They provide the standards, but then the question becomes, to begin with, are they voluntary or are they mandatory? And there are mixed messages that go out. They're called mandatory standards, but put out as voluntary, and the authorities consider them to be voluntary targets, and they consider them, but they don't feel compelled to comply with them. And as well, the department doesn't actually monitor or get any information as to whether these standards are in fact applied. And what's true in Annapolis will be true across the province.
So what's needed to fix that, in your view?
I think it's very simply a more active role by the department in all of these areas. And I know that they have referred to a framework that they're developing with DHAs to work with them to establish the rules, and that's fine. I think that's one way to go about it. It's not necessarily the only way, but if that's what they want to do, then they need to, in those agreements with the authorities, clearly establish a more active role for the government and the department in the monitoring and assisting the operations of DHAs.
Does it seem strange to you that there would be a lack of clarity around whether a standard is mandatory or voluntary?
Well, it's not a question, I guess, of whether it seems strange or not, but I think it's just something, an approach that has evolved over the years. And if the department has taken a very hands-off approach to delivery of health services in DHAs, and they produced documents like this and just simply have drawn back from detailed involvement in the organizations. And I think that's something that's evolved over time.
When you look at this seems to cross over both in terms of a number of these areas, infection control, and also with the addictions. You've almost found the same things, two different services, and found the same things. One of the things you just mentioned is that it sounds like they have a plan to try and work towards fixing this. I also note that when we look through their recommendations, I think they pretty much agree with all your recommendations and say, you know, we're going to do this, but they've said that in the past. Other departments have said that in the past, and part of your report is sort of the abysmal results in terms of compliance with the audit. So what hope do you have, or what level of optimism do you have that, despite the fact they're saying they're going to be done, that things will actually be done, since your report also points out that things that were said would be done in the past haven't been done yet?
Well, that's true, and but on the other hand, it varies from department to department, and so there are quite significant differences if you go comparing, say, community services and education. But the Department of Health, we've had discussions with at the senior level, including deputy, and they've given us assurances that they actually take these recommendations seriously and agree with our findings in the area. They made commitments last year as well, and were one of the departments that actually started to live up to these commitments. And they have, in the last year, made a strong effort to start correcting the deficiencies that have been found in prior reports. And not all reports. They've been working, it looks like, primarily from the most recent ones working back. But they have made an effort and have in fact talked to us several times about it. So I do have some belief that, yes, the Department of Health is serious and will make these changes.
You indicated just now even that some departments are better than others, and I think that it's probably not unsurprising. The departments that you pointed out as being not having as good a compliance record, why do you think that is? Because there seems to be more of a willingness in the Department of Health to address these things than some of these other departments.
Yeah. It's hard to say, looking at this, why this situation would arise. But let's perhaps try looking at it a little differently, and we keep looking at our recommendations, and it starts to look as if, oh, we're just telling the departments what to do, and maybe they like it or don't like it. But all of our audits look at a variety of programs. We have findings in each of these audits. The findings tend to be around, well, they tend to begin with, our findings are cleared with departments, and management, 90% at least of the cases, agrees with us that these are correct. They tend to identify deficiencies in the operations of the agencies or departments we're looking at, or in the programs. And these deficiencies can identify perhaps inefficiencies in their operations that can cost government money, ineffectiveness that hinders the program from achieving its goals, and in some cases points to risks to public health and safety, if you look at particularly the ones we just did. The management of these organizations, once they are aware of these deficiencies, then have a responsibility as management to correct the deficiencies, and that's really the issue. It doesn't really have, it passes beyond us at that point and becomes a managerial responsibility. And perhaps some management groups perceive that responsibility, and perhaps some do not. That's the only difference that I could see that would occur.
Last week you had talked about, and your report talks about the fact that the cabinet probably unwittingly was provided inaccurate information about the status of some of your past reports, and then ultimately the public, because the public got that report, and that Treasury Board has refused to sort of take responsibility for managing the system and making sure that those items are accurate. And I think that potentially feeds into exactly what we were just talking about with knowing what departments are doing. Why is it important that somebody, whether it's Treasury Board or somewhere else, I mean, Treasury Board seems to make sense, but it could be anybody. Why is it important that somebody or some department be responsible for ensuring the accuracy of information put in the system, which monitors the results of your audits and the compliance with them?
Well, the issue we have with this is not that this is information which should be accurate because we use it. I think that's beside the point. We can if we need to get our own information. And the true issue with what we have with this process is that information on implementation of recommendations and correcting of deficiencies is gathered together by somebody and is then provided to Cabinet. And I firmly believe that staff in departments have a responsibility when they provide information to the Executive Council to take some efforts to ensure that the information they're providing is accurate. In this case, nobody is taking that responsibility. So that members of Executive Council who then get this information and make decisions to act on it, like issuing reports and so on, are not not making decisions based on all the facts. That's the responsibility that we're pointing to in a report that has to be accepted by somebody in one or more of the departments.
Now, you noted that there were, in the time frame that your office looked at, there were 82 deficiencies, and in fairness, some of them were things that had been done and weren't marked done, right? So I just, for the sake of transparency, a lot of them were ones that were marked done and not done, but there were some the other way. Is it your expectation that that same finding would apply if you looked at it more broadly to other years?
We have no reason to think otherwise. There were 2 other years. The information we looked at, we were doing for the purpose of our our reporting in this chapter, and that one took us up to 2009. The report in question included 2010 and 2011 as well. So on the basis of, if you look at the years prior to that as being a sample, I think you could conclude the same percentage of errors would occur in the rest of the information, so that in total there'd be a lot more than 82 errors.
And the reason I ask is because I just wonder whether whether you had any indication that that had been corrected since that time period, but you have no reason to believe that it's been corrected.
At the point at which we were writing this report, I would say it's highly unlikely.
Okay, thank you. What is the, when we look at, back to the Department of Health, and I apologize, I'm all over the place, we've got a lot of different areas to cover. In terms of the addictions services in the Valley, what is the potential impact of the lack of oversight to the clients that are receiving those services?
In fact, for that one, why don't I pass you over to Ms. Coleman-Sad, who can deal with the issue.
Ms. Coleman-Sad.
I think to some extent it's difficult to say sort of exactly what the potential impact could be, but I think in any service, the impact of a lack of oversight, particularly when you have different districts and different hospitals in which those services are delivered, is you can get into situations where there are different standards in different areas. You know, one area might have a certain level of a standard and somewhere else might have a higher or lower standard. So you can get into sort of discrepancies in exactly what services patients are receiving in terms of the quality of those services and whatnot when there's insufficient monitoring and oversight.
So would it be, is it fair to say that there's the potential to put clients of this service at risk? I'm not saying at risk that they're going to die, but that that they could receive improper treatment or inconsistent treatment?
Ms. Coleman-Sad.
I think it's difficult to say if people could receive improper treatment. I mean, that's starting to get into the medical end of things. In terms of inconsistent, I think that potential exists when there's a lack of monitoring. I think it's important, though, to recognize that the district health authorities have a role to play in the monitoring of their own services as well, and in reporting that information up to health. I mean, I don't think we envisage the Department of Health and Wellness being out inspecting constantly, if you will, or anything like that. I think it's at a higher level than that, and I think the districts need, you know, to do their own monitoring and then report that information up to health, and then I think health needs to check on that in some manner.
So in the Annapolis Valley, have they, as the district health authority, not assigned somebody even within that health authority to be responsible for monitoring for compliance with the programs or the guidelines, I guess?
So towards the end of Chapter 3, there is a little section that talks about performance monitoring, and Annapolis actually does do some performance monitoring. We did have some recommendations regarding making sure they covered all programs and timeliness, but they do make some efforts to do monitoring of some of their programs, not all.
Yeah, and I'm aware of the section at the end there, but so the issue is really they're not monitoring them all and not monitoring them on a consistent basis. And I guess also that maybe they don't really know what standards they're monitoring them against. Is that fair? So
the issue is that just at Annapolis that all programs aren't monitored. And in terms of timeliness, there are certain steps that they take with regards to chart audits in an attempt to monitor standards, and we found they had done them for a couple of years, but not for a couple of other years. So that was an issue. But then also part of the issue is that then that information doesn't get rolled up and reported to the Department of Health. So there's that lack of oversight at the departmental level.
Is that essentially the same issue that you're reporting on at Cape Breton with infection control? It sounds like when I read the two of them and I hear what you're saying, it sounds like a very similar kind of issue, just one being infection and one on monitoring standards of.
Ms. Coleman-Sad.
It is largely a similar issue. There's not a specific section in infection control that relates to performance monitoring, and I don't know that there's as much sort of as formal a process for monitoring going on in the infection control area as there was at addictions in Annapolis. But it is, in terms of the department and the departmental oversight, it's certainly a very similar issue in that there's a lack of that knowledge in the department of what's going on out in the districts at a detail level.
I guess what worries me is that it seems you have two areas on opposite ends of the province, and it...
Order, please. Mr. Younger, your time has expired. Mr. D'Entremont.
Thank you very much, Mr. Chair. Thank you very much to the Auditor General's office to be in today. I want to start basically with the follow-ups of performance audit recommendations. Last week your office identified 82 errors in the provincial update. During the media and here in public accounts, you mentioned some mistakes that were simply that recommendations hadn't been upgraded. Can you explain maybe some of the recommendations or all the recommendations that were found to be erroneous outside the simple mistakes?
Here.
Yes, thank you. I'll, if you don't mind, ask Ms. McDonald to answer that question.
Ms. McDonald.
Thank you. There were 19 recommendations of the 82 that we found were actually complete once we sort of started looking in more detail, despite what was first provided in the Tagger system to us. And so that's good news. Some of that related to that there's sometimes a misunderstanding perhaps on what the recommendation is getting at. If it's referring to an ongoing process, sometimes the department might think that it actually could never be complete because it's an ongoing process, and we say, no, you know, you've done the work to address the recommendation and you might have to look at it on an annual basis, but for now it's complete. We also saw that there were, you know, about 40 recommendations where there was, the status was downgraded from complete to some other level, and then the other recommendations, they would not have been complete, but the status that was reported was inaccurate. And the range of explanations as to why they were downgraded from complete to some other level is, you know, sort of varies from the information that was in the system. When we looked at it, it really wasn't complete. It didn't provide, you know, the full implementation of the recommendation. An example might be that, you know, perhaps regulations, we recommended regulations be updated to a particular act, and that hadn't been completed yet. So there's a variety of reasons. There's not sort of an overall comment to be made, but certainly we looked at in detail at all of the recommendations, with particular emphasis on those that are complete, to find out whether the information supported that the recommendation had been implemented.
Thank you very much. When the provincial update is coming out with errors of this nature, can we trust that the province is updating us correctly on the progress? I mean, it's a trust issue that to me it looks like that. Is it a miscomprehension of how the system works, or is it simply that they can't be bothered with the recommendations as they're getting them? I mean, what's your feeling on that, or what do you see? And that's for either, I guess.
I'm not sure that we can make an overall comment on how departments are dealing with the recommendations. We certainly found in the Department of Education that the information in the system was sometimes incomplete. There was actually nothing in the system. There would be the recommendation and then the detail that supported, there'd be the recommendation, the status at whatever it was noted to be at that time, often noted as being complete, and then no information, literally no information to support that status. And then, you know, we do some more digging around and find out that in fact it wasn't complete, or perhaps it was complete. But so I'm not sure that we can make an overall comment about departments and their commitment to updating the Tagger system, but certainly the information that ultimately made its way to the public, there were, you know, sufficient deficiencies that we had felt we had to report it.
You've mentioned in a couple of the other answers to my colleague here, you know, some departments have superior recommendation implementation records, others, of course, not so much. Education, as we just mentioned, seems to be one of those that hasn't kept pace with that pack. The Department of Education, apparently, from the documents, have completed 14% of the recommendations in 2010 and 13% in 2011. So I'm just wondering, you know, why such a low record, and how are we going to work with the Department of Education, for example, to try to bring that average up a little better?
Mr. Lapointe.
Yeah, you know, it is hard to say, as I mentioned before, I guess, why any one department would have a very good record of dealing with the deficiencies and one not. But the facts with education are that when we pointed out last year, the low level of implementation in health and in education, that senior management at education told us that they would make it a priority to make a change in this. And for whatever reason, it might have happened in the past, sometimes just from, it could be inattention, we don't know, but they decided that they would make it a priority and deal with it. And since that time, virtually nothing has changed. So I don't know then why the dynamics are as they are in that department, that they apparently don't take these recommendations seriously or take seriously the deficiencies behind them that we're pointing out.
A lot of the recommendations we see are in some cases issues of public safety, like ensuring child abuse registry checks and criminal checks are completed for hiring the employees in their schools. Some of the recommendations are essentials like that one that just not seem to be getting done. Is it a problem of delineation of whose responsibility is it? Because I know we hear a lot and that it's responsibility of the school board and not the responsibility of the district health authority or of the department. So is there a problem between you know, the oversight of the department and the actual workings of the school system at the more ground level?
Well, I suppose that there's a possibility that this is yet another decentralized department in which, you know, agencies are delivering the services. So it could be that that's one of the factors, adding some complexity to say who takes responsibility for some of these things. But I wouldn't say that could be the sole reason. It might be one of the factors playing into it. But as I mentioned earlier, once deficiencies are pointed out in the operations of a department or its agencies, and that might affect either efficiencies and cost or effectiveness or public safety, then from a managerial point of view and a governance point of view, it's the responsibility of the senior management to deal with the deficiencies regardless of who points them out. It could be their own staff. So what's not happening here, for whatever reason, and I can't speculate on that, but for whatever reason, the senior management in this department doesn't appear to have accepted that responsibility that I believe they have to correct weaknesses in their own operations.
I think we've talked a lot about the communication informational request experience with the department. I think you've talked about how that's gone on or not gone on with that department. You know, the Auditor General has just said that you know, there's issue with maybe taking responsibility for these changes. So, you know, when one avenue doesn't work, well, there's a way to get out a bigger stick, and of course that's working with the central part of government. There are managers for those managers, which in my estimation is Cabinet, Treasury Board, and those outfits. Is there a role for them to play in not pushing down on the department, but at least ensuring that department takes these recommendations seriously?
Yes, I think there can be, certainly. You are hampered, I believe, to some extent by the very decentralized nature of the Westminster style of government that, you know, does actually make all departments equal. There's no head office in our style of government. No. And it's not just here, but you'll find in other provinces that can be a hindrance in driving change from the center. What department can tell other departments what to do? That's certainly one of the complicating factors, but it's still possible to provide direction from the center. I wouldn't presume to say exactly how that should occur or what the driving force should be, but whether it's through Treasury Board or anywhere else, that is, I guess, a management decision.
I understand that all departments are sort of created equal, yet I had the opportunity to sit at a cabinet for a number of years and knowing full well how those discussions go, and knowing full well the bigger stick that the Premier holds or the Minister of Finance holds or other folks in there when it comes to your funding, your what have you in that. Is there a mechanism that you could suggest that could provide a better, I mean, we have a tracking system, but the tracking system is only good as the data that goes in it. Is there a suggestion that you would have, or maybe an experience from another province that they deal with, the true implementation of the recommendations that you bring to government?
Well, I don't think I can really, point out one particular way that has to be done. I think if the change has to be done, it certainly needs some direction from the center. In what way that occurs, really not for me to say. But I know that some direction from some central group that may be authorized to do so can certainly have an impact. And more importantly, I suppose, is a need for a bit of a cultural change throughout all the departments and agencies, that they simply begin to accept more of a managerial responsibility to correct weaknesses that are pointed out to them.
Do you find, and then maybe this is the recommendations again that have not been implemented, or at least we're not sure, are they not implemented from your experience because of funding issues, or is it just, again, an issue of not understanding the importance of putting these things in place? Because I remember a lot of discussions, sometimes there are costs to be bound by these recommendations. So do you find them that way or not?
I doubt that it's significantly a cost issue. It might be in some cases, but in that case, we're prepared to accept that and understand it. Yeah. If the explanation for something still being in progress is that it's hard to find money for it, and I admit that there are some times which we say, as we've said, for instance, in infection control, that some money must be spent because you don't have enough staff involved to make this work, so you do in fact have to add more staff. Well, where does the money come from that? That's not the primary issue in most cases. Most of the recommendations we make, I would venture to say, don't have really significant cost implications, and in some cases, the benefits that you'll get from them will outweigh the costs. The infection prevention and control issues, for instance, have the medical belief on these issues that we've seen written down are that the cost of allowing hospital-acquired infections to occur is much greater than the cost of putting in the measures to prevent them. So in fact, where you might have short-term spending of some money on these things, in fact, the end result is to save money. And that, to my mind, is almost an ideal recommendation, one that in the long term saves money and also adds efficiency. The issue that I'd point to would not be cost, but simply a commitment to accepting responsibility and making the change.
Moving up a little bit in the recommendations, and there were 29 recommendations on infection control at Cape Breton. There were 13 recommendations when it comes to addiction services. Some of them do revolve around public and patient safety. Some of them, are more control issues and trying to realize whether we're getting, a good service or not. Do you feel, moving over to the Department of Health and Wellness, and we spent some time on education, do you find that they're providing enough oversight to the district health authorities when it comes to the implementation of these recommendations?
In terms of the infection prevention and control issue?
Sure. Yeah. Pick one.
Well, no, certainly what we were concluding was that the oversight in that area was too limited. And particularly if you look at the group that was established, as an example, for at the department to oversee infection prevention and control, appeared to be a very effective group. Seem to know what they're doing, but there are only 2 of them. And the mandate that they were given was really quite large. If they were to actually go out and attempt to provide support to districts that have outbreaks, to provide guidance to them, to provide direction, there's simply, and to monitor what's occurring across the province as a starting point, they're not able to do that. So clearly the department, through that, if that's the mechanism they're using to provide oversight in that particular area of infection prevention and control, they simply are not doing it.
2 people taking care of 9 district health authorities plus the IWK would, in my mind, would be not enough. And we know that each district health authority would have their own infection control people. Yet trying to monitor across the province, especially looking at the travel of patients from one district to another, or coming to Halifax for tests, for a whole ream of different reasons of why you'd have the transfer of those patients. What do we see as maybe an alternative to that recommendation? Or we've got 2 people. What would the recommendation be? I mean, ultimately, it's probably get a few more people in there or change their role just a little bit.
I would say that their role was properly developed. The mandate that they were given and the description of what they're meant to do would certainly be effective if it was put in place. So our feeling with that one is that the group, as it was developed and mandated, needs to be given the capacity to do, as a starting point, what they were mandated to do. And I think that alone would have a major impact. If the department then wants to look at doing more later, they can, but at the very starting point, let the group that they have created have the capacity to do the job it's meant to do.
Did it seem that the district health authorities didn't accept that oversight, I guess is what you maybe would call it, or they don't like, Halifax intruding in their day-to-day business?
I wouldn't say that we've run across any such feelings that came out in our audit. We have nothing documented that would show that that there are these kinds of tensions in the areas that we looked at.
When looking at, and this is sort of continuing on that a little bit, when hearing from the senior management of the Department of Health that they have plans to improve that district accountability, whether it's mostly in infection control, for instance, they want to have signed accountability agreements. Does that change anything, or does that just sort of give you another piece of paper that might look good in the end, but is more of a trying to trying to solve it with a hunk of paper rather than actually doing something?
Well, it has the potential, of course, always to just be another piece of paper, but I don't think that's the case. I think it could be quite helpful for the department and the districts to have these discussions and to put down on paper clearly the roles of their respective roles, so that in that those documents, once they've written them and agreed on them and signed off on them, it clearly outlines common agreed responsibilities, and including in there the expanded, if you could put it that way, role of the department and in terms of oversight and monitoring. I think that could only help the situation.
I know I'm getting close to my time on this one, so I just want to move to the issue of the Valley, and more specifically in recommendation 3.3. It recommends the Department of Health and Wellness, quote, should revise its addiction service standards so that standards are measured where possible. So my question is, are general statistics maintained for patients in the healthcare system, or what do you see as being adequate statistics being kept?
If you don't mind, I'll ask Ms. Coleman-Sad to speak to that.
Coleman-Sad.
Thank you. So this recommendation deals specifically with addiction services standards, so I'll respond in terms of those. Many of the existing standards are really not measurable, or leave out pieces of the portions of the population. For example, 80% of patients should be seen within X days, and then it never speaks to when the other 20% should be seen, so presumably they could never be seen and the standard could still be met. And so we wanted to make sure that standards are measurable, and just that standards are that they take a look at the addiction services standards and make sure that they have the best possible standards that they can have, because some of them are quite, as I said, limited in terms of covering the full population and whatnot. So there are some statistics available on sort of addiction services and, wait times, who's seen within what time periods and whatnot. But all of the standards are not measurable, and it may not be practical that every standard be measurable, but as many as possible, if they could be,
Order,
I think would
please.
be helpful.
Mr. D'Entremont, time has expired. Mr. Ramey.
Thank you very much, Mr. Chair, and thank you all for coming in this morning. I'll probably focus my questions around Chapter 2 and perhaps Chapter 4, depending on how we do on time here. I had a look at the recommendations specifically for the Department of Health, and it looks to me like more progress has been made since 2009 on the 2009-2011 recommendations than there was between 2005 and 2009. I'm wondering if I have that correct, and if you could comment on that, please.
Ms. Coleman-Sad. Ms. McDonald.
Thank you.
I'm working my way down the line here.
Thank you. We didn't do any work on the 2011 recommendations. Our chapter covered 2005 to 2009. So I can speak to that by saying that certainly what we found is that the recommendations that the Department of Health and Wellness were responsible for in the later years, so 2009, that there was a higher implementation rate than of the earlier years. So in 2007, 2008, there were a couple of prominent audits in long-term care and in home care. We found the implementation rates there were not good, and we've suggested and recommended that efforts be made to improve those implementation rates. With respect to 2005, 2006 recommendations, from last year, we noted that only 4 additional recommendations had been implemented, and we've concluded overall for all departments that those recommendations in 2005 and 2006 that have not been implemented to date, that there is a failure to implement at this point in time.
Okay. I understand that the Department of Health has implemented 20% more recommendations since your last review. Is that accurate or inaccurate?
That's accurate. Their rate last year was 36% and increased to 56%.
Okay. And I think I heard this commented on before, but I just like some clarification on it, and I'm switching now from Department of Health to Department of Community Services. Was I correct in understanding that the Department of Community Services has the highest rate of implementation for recommendations? And if that's correct, could you comment, or someone comment as to why you think that is?
Mr. Lapointe.
Yeah. The community services has the highest rate at overall 85%, and that's fairly consistent with the approach in that department from that we've seen in prior years. And you're right about the Department of Health, as I guess mentioned earlier, having made some efforts to start implementing recommendations, but starting with the more current years and I guess working backwards. We have had discussions with them about that, and they do intend, as they say, to continue working on this. But as to the motivations behind this, and specifically why any one department would be different in rates from another department, we have no way to know that, and all we can do is report what we find, and not try to speculate as to why the management in the community services and health would be different in their results.
Okay. I'm switching now a little bit off that topic to Chapter 4. And Minister MacDonald set up a patient safety committee in 2010, and the first and I believe the first and only kind to provide central oversight. Could you comment on what role you think that committee maybe played in bringing C. difficile outbreak, the C. difficile outbreak, under control?
Yes, I'll ask Ms. Coleman-Sad to speak to this.
Ms. Coleman-Sad.
Thank you.
I don't recall from our audit there being a significant role for that committee with regards to C. difficile in Cape Breton. That's not to say that they didn't play some role, but I don't recall anything from our audit files dealing with the role that that committee might have played.
Okay, well, I guess following perhaps along in that vein then, in the spring session of the legislature, our government introduced the Patient Safety Act. I guess the follow-up would be, do you think this legislation is a step in the right direction in terms of what we've been talking about here?
I mean, I think certainly anything that that speaks to patient safety and whatnot, you know, and that looks at greater oversight and whatnot is a step in the right direction. I think there's significant work that remains to be done in terms of the department's oversight of the district health authorities.
I know that we were talking about DHAs and the control they have sort of over their own destiny, and Mr. Lapointe was commenting on the parliamentary system and sort of how some of these things work. The Patient Safety Act sets clear outlines and requires DHAs to do regular inspections. So because it does, do you think that is an improvement in the overall scheme of things?
I think so. I think it's important as well then that there is oversight by the department to make sure that the districts are complying with that act, and that the districts are doing the inspections, and that the results of the inspections, if they're not acceptable, that something is happening to move things in, you know, in a better direction if there are issues as a result of those inspections. So I think it's important that things get reported up to the department at the end of the day out of those inspections at the district health authorities.
So, so based on your answer to that, I think I know your answer to this, but I'll ask you anyway. So do you think we need to have one standard across the province for training levels in infection control?
There are many different sources of best practices in infection prevention and control. They tend to be 70 or 80% similar, and then there's small differences between. So I think it's possible to have slight differences from one district to the next and still meet sort of the overall basic standard. I think someone needs to look at what that overall basic standard should be and say at a minimum, and there may be more than one training program that meets that minimum. It may be that there are a few different training programs that meet that minimum, but I think it's important that, you know, centrally somebody like IPCNS say, well, for example, you know, here's sort of the bare minimum of what an infection prevention control practitioner should have, as an example.
Okay. I know I have a number of colleagues who are also interested in asking questions, so I think I might pass it over to my colleague, Mr. Wynot, with the chair's permission.
Mr. Wynot.
Thank you very much. Excuse me. Thank you very much, Mr. Chair, and thank you for being here today. I want to go into Chapter 3 a little bit around addiction services at the Annapolis Valley Hospital District Health Authority. And if we all know that addiction services is something that's so crucial in the way we deliver care to people. And while I think you were doing your audit, we saw a implementation, or I guess not implementation, but a gathering of information to come up with a strategy around mental health and addiction services for people in Nova Scotia. Did you see any of that work taking place while you were, conducting your audit?
Mr. Lapointe.
Well, I can say in terms of timing that occurred after we were doing the work, but so this would be subsequent to what you see in here.
Okay, thank you. Good clarification. I appreciate that. In your review of addiction services down in the Valley, did you find any examples of policies or programs in place in our system that were actually best practices and that we can learn from and kind of implement across to other district health authorities across Nova Scotia?
want to speak to that?
Ms. Coleman
Ask Ms.
Sad.
Coleman Sad then.
So with regards to, I guess, Annapolis Valley and potential best practices, one area I think that Annapolis, although there's still room for improvement, they were at least doing some performance monitoring of their services, which I think is excellent. You know, timeliness and sort of completeness in terms of doing all services was a bit of an issue, but at least they were making some efforts in that regard. I think that's an area that's important. Another interesting area that I know Annapolis feel is sort of on the leading edge of things is their opiate treatment program and how they're implementing it, because opiate treatment is often long-term treatment, and there are often huge wait lists to get into it, and they're hoping to engage family doctors. So I think it's too early to say if it's a best practice yet, but on a go-forward basis, I think that program will help to illustrate whether that model or the typical model is what is maybe the best practice in that area.
Okay. Did you find any evidence that people with addictions in the Valley had to wait an undue amount of time for treatment?
No.
Mr. Lapointe.
I'll ask Ms. Coleman Sad if you don't mind.
Ms. Coleman Sad.
Speak to that.
Generally speaking, people were seen, I think it was 89% is the statistic that we quote in the report, were seen within the wait time standards. So there's 3 different categories of patients, and there's a standard for how quickly each category should be seen. So some might be an emergency or supposed to be seen kind of within a 24-hour period. And generally speaking, they were seen within wait time standards. There were some that fell outside of it.
I remember seeing, I think one of our committees, standing committees, we saw a presentation on that. I can't quite remember the standards in the 3 categories. Are you able to just clarify that for folks?
So emergency priority are to be seen the same day, urgent priority are within a week, and general priority is within 3 weeks. It's on page 51 in chapter 29 paragraph 29 of that chapter.
Okay, great. I appreciate that. I think it's good for the abundance of people that are watching at home today that it is a good thing for them to realize that there are standards, and you know, that unfortunately there are 11% of people who kind of may not have fallen within those standards, and hopefully with the help from the province, the health authority, and we'll be able to, you know, address those issues. And I mean, it's good to hear that there, you know, it's such a high level of high percentage of people who are able to, you know, work within the or being able to see and being cared for in that amount of time. So I understand that there are different challenges to maintaining and monitoring wait lists in addiction services. Can you comment a little bit on some of those challenges?
So some of the challenges that addiction services staff in Annapolis and I guess at the department as well identified to us is sometimes with addiction services patients, when they're on a wait list for a particular service, depending on how intensive that service might be, it may not be the right time in their personal or perhaps their professional life to move into a treatment program. So they may be on a wait list and perhaps are the next person in line, but maybe it's a program that requires being off work for 2 weeks and that isn't possible right now, or they don't have childcare. There's all kinds of reasons that could play into that. So there's some challenges in that regard, and one of the other challenges that was identified to us with regards to addictions clients is that, you know, it's a population sometimes that might start service, and then sometimes people stop services and then need them again in the future. So, you know, it's that sort of having to come back to the services again later sometimes is a challenge as well.
I'm certainly not an expert in this area, but I guess my next question is around who are the trained professionals who are providing these services to Nova Scotians? I mean, are we talking specifically social workers, or are we talking other types of healthcare professionals? Can you comment a little bit on that, or do you? Yeah.
A little bit. I mean, our audit would have sort of touched on that a little bit in terms of when we did our testing, we would see who was providing services and whatnot. There would be a variety of healthcare professionals that would be involved in providing services, and it would be, you know, those that you mentioned. Family doctors would be included, psychologists, psychiatrists. There's all kinds of counselors of various kinds. So it just depends on the program and what the needs of the patient are.
I know some of the things that we've seen in reports and that sort of thing is this whole model of patient-centered care, trying to, you know, encourage the family doctors in Nova Scotia to move to this whole model of patient-centered care, to allow them to open up and really have incentives to open up an office where you have access, direct access to these sorts of healthcare professionals, which I think is a good model. And not that I'm an expert, but it does seem to me that if Nova Scotians and their families are able to access that care right in their own family doctor office, it seems to me that it does make sense. And if that's the model that we're moving to, I think that's a good thing. And I know that you know it takes time in order for that switch to happen. But if people who do have issues with addictions and even mental health issues are able to get some sort of care within that model, then I think that's a good thing. It's a good step forward. Nova Scotia, I think, is being seen as an innovator across the country when it comes to healthcare delivery, and I think that piece is just one part of the puzzle, how we can change that. Ms. Coleman, had you mentioned a little bit about the new opiate treatment program in the Valley. I understand that treatment program was implemented during your audit. Can you speak to the process that Annapolis Valley Health went through in order to implement this program?
I don't have a lot of details on sort of how they came to the decision, for example, that particular program model was the appropriate model or anything. It was a gap that we had identified at the beginning of our audit that we knew they were working on, and it was implemented during our audit. And, you know, we looked at what are they doing, what service are they providing, that type of thing. We didn't get involved in sort of all the process that had led to the decision to implement that particular program versus a different type of opiate program.
Okay, fair enough. So overall, it sounds like the Addiction Services Program is functioning, you know, quite well. I mean, obviously there's always changes that can be made. You noted that their policies, programs, their staff training, and communication with the public and others adequately meets expectations and really the needs of the community. Is that a fair assessment of your findings?
It is. Our findings with regards to Annapolis Valley's addiction services program were fairly positive. I mean, as you say, there's always room for improvement, and there were areas for improvement identified, but overall we found those services to be well managed.
Great, thank you. I know I think I only have about 3 minutes left. Yeah, okay. I do want to ask a question on Chapter 5 around the Nova Scotia Prescription Monitoring Program. So I don't know, is that Ms. Coleman's hat as well? Yeah. How do we compare to other provinces when it comes to monitoring of prescription drugs?
Say that again.
Ms. Coleman said.
So we don't look at what other provinces do when we do our audits for, you know, a few reasons. Some provinces I know have monitoring programs and some don't. But in terms of a comparative to Nova Scotia's program, we don't have any mandate to look at those program areas, and you can't always rely on what's on websites and on the internet. You know, you don't know that it's complete and accurate information when you haven't audited it, so we don't do that comparison.
Okay, fair enough. I know that, just as a comment, I think I understand that a number of provincial jurisdictions have actually praised our prescription monitoring program and really have taken our model and you know tweak it to their own, but have been able to implement their own drug monitoring program, which I think is a positive thing. As I mentioned before, having seeing Nova Scotia as a leader in healthcare delivery. I think that's a good thing. So I did want to make that comment, and I think with that, Mr. Chair, I will leave my time and go to the second round. I appreciate that. Thank you so much.
Thank you very much. The second round will be for 16 minutes, and we'll start with Mr. Younger.
Thank you, Mr. Chair, and thank you. I want to get back to something that I think all members at various points have been talking about, which is sort of the compliance issue with various audits. And when we go to sort of, I guess, starting on page 16 or thereabouts of the main report, it talks about the different departments, and I want to talk about the different departments in the current stance in terms of compliance. For example, I think you'd mentioned, Mr. Lapointe, that some departments are better than others, and I noticed actually it looked like natural resources was pretty good, but when I go through them here, it says that, for example, Department of Health and Wellness since 2011 has only implemented 4 of the 46 recommendations, the earlier recommendations, and then it makes the comment that the lack of action is contrary to what the department promised last year. And then there has been little or no progress by the Department of Transportation Infrastructure Renewal or the Department of Justice on those earlier ones, and no progress by the Department of Education. So I guess I'd like to get a sense of what departments do you think are doing well to clear that backlog? I assume some are.
Well, thank you. I might get Ms. McDonald to see if you can shed some insight on that too, but I'd say that as a general rule, what we were finding was that you'd reached almost a plateau with the really older recommendations that we were looking at, going back to 2005 and 6 and 7, and that any good progress overall, you're probably going to find lies in the Department of Health in the more recent. So at a certain point, we simply decide that we're not going to see more progress in the older ones, and we simply, when we say we'll take the view that we consider them as having been failed to be implemented, so we simply are going to cease tracking them. Given that, I don't know if we had any that specifically might have done well in the older ones.
Ms. McDonald.
Ms. McDonald.
Thank you. No, I can't say that there are any departments which stand out with respect to the older recommendations, and I'm talking those 2005 to 2006 as having significantly improved their implementation rate of those recommendations since our review last May. The chart on page 21 gives an indication overall of the success of implementing our recommendations by department, and certainly you'll see there that Department of Health and Wellness improved. With respect to other departments, there's really not been a significant change, and really some departments, I think we indicated in paragraph 233, for example, Department of Natural Resources, that they improved their implementation rate, but there weren't that many recommendations made to them in the first place, so implementing 1 or 2 more actually increases their rate significantly. So.
That's a fair comment, and I note how low the implementation rate is for the Department of the Environment. It really quite stands out in that chart.
That's the Department of Education.
That's Department of yes, sorry. Yeah, it's the abbreviation. See,
yeah.
You're right. Which is even worse in some respect. And I want to talk about the Department of Education in a second here. I guess what concerns me about it, though, is, and it's fair to say that, because I've heard some people say, well, fine, these were in 2005, 2006, that was previous government and all that, but some of these, there were commitments last year by the current ministers, well, ministers have changed again, but by the current departments to try and implement those older recommendations, and your office refers specifically to the Department of Health and some of the others saying, listen, we know there's a backlog, we're going to get at them, and then you come around here a year later and it says, but nothing really happened. Is that, or very little, I guess nothing is too strong. Very little happened since the commitment was made by the departments a year ago to try and address that backlog. Is that fair?
Mr. Lapointe.
Yeah, I can, I think, address that. Yeah, so we're, that comment applied specifically to education and commitments made to us by senior management at that time. There was a commitment I had mentioned by Department of Health as well, and they have actually been clearly making some efforts, and that's something that we're aware of as well. Well, we're looking at this not from the point of view of, you know, which particular government might have been in power at the time the recommendations were made, but this is an ongoing issue within the management of these organizations, which is, you know, as we know, continuous, whatever government changes might occur. So this has been an issue for some time, certainly since I've been in this office. I suppose we get a little repetitive about mentioning it, but it's something that I think does need to be addressed and has been ongoing for as far back as we're tracking here.
And I agree with you that I think it's an ongoing issue, and it's striking me in reading this report that it seems to be somewhat systematic, and I'm not sure why it's happening. And you raised the Department of Education, and I would like to talk a bit about that, because on page 22 of your report, there's a paragraph that talks about, paragraph 2.40, which talks about, if I'm understanding what you're saying here, the response that you got from the Department of Education. It sounds to me like the Department of Education was even reluctant to be cooperative with you on trying to get information on the status of doing the work, and then there were discrepancies, and it says information requested to support statuses as well as management agreement on change of statuses was not provided on a timely basis, and in some cases information finally provided did not address the issue raised, and we had to seek additional support. I assume that you are pointing that out here specific for this department because it was unique in your dealings with departments, or the level at which you received resistance. And I wonder if you could speak a bit about the resistance you had from the Department of Education to your work.
Yes, that was specific to this department, and that's one of the reasons why, since it stood out, we mentioned that specifically in here. But as to the details, I'll ask Ms. McDonald to tell you more about it.
Thank you.
Ms. McDonald?
Thank you. With respect to the Department of Education, our experience this year was, I guess, less than good. We just found that we sent requests over to get support. So the way the process works is that the status is indicated in this tagger system, which we use and which government had developed. We look to that to see what the latest status is noted. We look to see what the support is for that status, and then we focus on those recommendations that are noted as being complete, and we ask for, can we have the information that supports that recommendation is in fact complete. So those requests would be sent over to the Department of Education. We were not getting responses back to our requests on a timely basis, so we would have to go back to them and ask, you know, when can we expect this? So then we finally said, you know, we need this by a certain date. So we started to get some progress, but it was a frustrating, I guess more than anything, it was a frustrating experience, and that's why it's highlighted here in terms of cooperation with our requests. I can't comment on kind of their commitment to implement recommendations, but certainly from the perspective of conducting this engagement, it was frustrating to be constantly asking, receiving delays, and then when we did get the information that we asked, or rather a response to the question, it sometimes didn't address the question that was raised, so then we'd have to go back. So overall, not a great experience.
Did you have any indication of why there were so many delays or problems?
No, there was no sort of overriding comments that were made to us. When we started to elevate the questions and bring in more senior staff, then they were dealt with a little bit more quickly.
Are there any recommendations that your office can make to solve that? I mean, I would hope that this will never happen again, but it's almost like it's undermining the Office of the Auditor General and the role that you're supposed to do on behalf of Nova Scotians. And I've said this before, but I think that departments have a right to disagree with your recommendation and say, listen, we disagree and we're not going to do that. And you see that sometimes, and that's fine. At least if they give the reasons, the public can make a decision, the legislature can make a decision whether they agree. But this is different. This is almost undermining or thwarting your attempts to do your job. And I just wonder if there are recommendations that you can make in terms of a procedural change or legislative change, or anything that could help prevent that sort of thing happening in the future.
We actually have a meeting with the Department of Education next week to discuss the results of this review and also, I guess, overall our audit approach. And hopefully, after that meeting, we will, if there are improvements we need to make in how we ask questions, then we're certainly open to suggestions. And hopefully the result of the meeting, though, will be an understanding of a more cooperative nature for next year's assignment.
Did you sense the department took seriously the importance of the work you were doing?
Well, sorry.
I do the same thing.
I guess that the frustration we experienced had to deal with getting responses to our questions, not dealing with the importance of the recommendations. So I just want to differentiate that. So I can't comment on whether they were, in any way trying to thwart the process of implementing recommendations or paying less attention to recommendations. I can't comment on that. Just though that as we tried to get support and answers to our questions, it was a frustrating process.
All right. When we look at I know you've laid out the report slightly different this time, and personally, I like it with the recommendation and then the response from the department. I think that's very helpful, so I congratulate you on that. I hope other people like that too. But I wanted to ask something. It's something that stands out in that is that when we look at the Office of the Trustee, the public trustee, which I think is at the back, if I remember the numbers, yeah, number 6, their responses are very different from some of actually any of the other responses I've ever seen, because not only does the Office of Public Trustee, they agree with them all, and that's fine, others do, but they say, not only do we agree, but this is the timeline under which we expect to implement it, for almost all of them, which then allows, because we've been talking about this compliance issue, and this allows you to not only, and the public to not only measure whether they've done it, but whether they've done it reasonably within the time frame that they suggested and the urgency that they place on a recommendation. Do you have any comment on the difference in how they've responded versus you see other departments respond to the recommendations?
Mr. Lapointe?
Yeah, I can talk to that issue of timelines. It is something that we've started to encourage in the responses from all the auditees, because for the reason that you say, that we have been asking them, particularly now that we're putting this right into the body, that whether they agree or disagree with the recommendation, but also we want to know from them whether they intend to implement the recommendation, and then if so, in relatively few words, what are the main actions that they intend to take. But then we've also been encouraging them to start giving us timelines, and you'll see them occurring elsewhere as well. But I'd say this office of public trustee simply complied very well with our request to provide information in that way. And it does help now to be able to see what kind of action they're going to take. Are they going to do this in the next 6 months or over the next couple of years? And we've already, in fact, I have had a discussion with the public trustee about a couple of the timelines. It seemed to me that a little lengthy, and I discussed ways in which she might be able to do some of these sooner. So it's very helpful from a very practical point of view, and I think it's a step in the right direction.
Well, I would agree, because I think what we're seeing now is recommendations from 2005, 2006 that somebody said, yeah, we agree with, but 20 years before we get to it. Is it your intent, and you're right, actually I hadn't thought about that, it allows you to comment and have a discussion with them whether you think the timeline is reasonable. It also gives an idea whether you think, or it gives you an idea of the importance that they've placed on each recommendation. If it's something they're going to do immediately, obviously they see that as critical or easy to implement. If it's a couple of years out, they obviously don't see it as critical. When you do the future compliance monitoring of this, do you intend to also look at not only whether they've done something, but the timelines in which they suggested they might be doing this? I realize this is sort of new. It's the public trustees the first one to lay it out so completely, but
yes, but certainly this is something we'd consider then in going forward. If they indicated a timeline of 6 months and 2 years later we're still in progress, then we'd have to question. That would be one of the recommendations we'd have to perhaps question and see what's going on. Whereas if they tell us it will take in fact 3 years, we would not expect when we go back that it would actually be finished. So it gives us a good indication of what's happening when we do return. But as you say, it does help us as well in immediate discussions with them in seeing whether they fully perhaps understand the recommendation. An example with the public trustee was the one, I guess it's their final recommendation, in which we recommend that they put in an accounting system. Understand that this is something we found when we're actually auditing their financial statements, that they're a $9 million operation in terms of spending, and they don't, have a general ledger. So if they were a corporation, and I was their accountant, I said, I would advise you that you simply must, have an accounting system with debits and credits and general ledgers and journals in a normal way of things. They've been operating with other ways of recording things that have developed over the years. And
Order, so please. Mr. Younger's time has expired. Mr. D'Entremont.
I'm so interested in this response that I think I'm going to let the AG continue on here.
Oh, thank you. Well, continue where I left off.
Hey, please.
But when I then had our follow-up discussion with the public trustee, we do this in every case before we issue. When I discussed this, I realized that they were looking at having a big study and analysis of what their needs were and how they might go about it, how they might fund it. It was all going to take a very long time. And so I was able to explain that really what we were talking about was to simply go out and get some professional advice, perhaps, but to buy an off-the-shelf accounting package like ACPAC and get some help from a good accountant to implement it and put in a general ledger. And it's not we weren't recommending a very big, complicated project, but in fact a very, very simple one of the kind that I would have recommended if I'd been, in my previous life of their accountants coming in to do their books. And so that I think they had a better understanding of what really we were talking about, and they might have had a misunderstanding and not actually taken effective action if we hadn't seen that timeline there and asked, well, why would it take so long? So that little aspect was quite a benefit of the way they responded.
Thank you for that. I would think that buying simply accounting or ACPAC would be a good avenue on that one. So I think that's very interesting. I'm going to move over a little bit, and it was a comment that came from the government members in this committee. It's sort of this apparent feeling that an election presses a reset button when it comes to the implementation of recommendations. So I'm just wondering, what's your feeling at this point? Because we sort of have this government's, apparently this government's recommendations and that government's recommendations. Does that seem to happen often, or do you see that happening here? I know it's been echoed by the members here, but do you find that within the departments?
I don't think that it's an issue of which government is in place at any particular time when we make recommendations. I know some of these go back to a prior government and so on, and in terms of when they were made, and some to the current government. We attempt not to take that into account in the work that we do and our recommendations to the departments, and look at the work we do for them as being to the perpetual organization, regardless of what might be happening at the political level. And I think that what we see too at the departmental level is that's how they treat it as well.
Yeah, and my feeling too is government regardless of who's at the helm. You know, the recommendations that come from a certain time are still opt for implementation by the current government. So I think that's an important standard that I think government should take. I'm just wondering, we talked a little bit in my questioning last time with the errors in the provincial update. I'm just wondering, is there going to be an updated document that we could have that sort of addresses some of the things that were laid out in your original document? Just, you know, if we found 19 of them that were actually complete, but were actually showed incomplete in the previous report, is there an update that we can get of that?
At the current time, I'm not aware of any document that reflects changes that we're making. The timing for a second provincial update, I guess, is fairly soon.
Okay.
We don't have any knowledge of what will be done in terms of the information for that, feeding into that report. What we would expect is that the findings, the changes that we made as a result of the things we looked at, would be changed inside that tagger system. We would assume that they would do that since we pointed them out to them, and would expect that would be in.
I'm just wondering to the chair, is there a way that we can get a copy of the tagger, or so that we see the updated version, or do we have to wait for the provincial update? Maybe a question for staff later on to see, because if there are changes, it'd be nice to see the updated version of that since the last meeting.
Maybe I could ask Ms. McDonald to provide a little more information on that too.
Ms. McDonald?
Sure. With respect to the 2005 to 2009 recommendations, the details of the current status is actually on our website.
Okay.
So if you look there, they're listed in every recommendation. Now, with respect to 2005 and 2006 recommendations, the status is noted as failure to implement, because that is where we are with
further
those.
on, yeah.
From 2007, 8, and 9, the status that is noted there is the one that has been agreed upon, if you will, between us as a result of our work and the departments at the end of this review. And those are listed there by their current status. And certainly we're hopeful that those current statuses will be updated in this system for government then to be able to use on a go forward.
Okay. Thank you very much. No, just in the issue of clarity, and because I mean, in your original answers, you were talking about the update or the changes in status, that some of them, just by simply asking the question and looking further detail into it, that there were some of those statuses that did change. So it's good to know and good to have a good look at that one. If I switch over to more detailed within it, looking at the recommendation to the Treasury Board itself. I think it was recommendation 2.2 that read, Treasury Board office should implement a quality assurance process to ensure information reported on the implementation of status of recommendations in the tracking Auditor General Recommendation System, or TAGR, is accurate and complete. And apparently the answer from Treasury Board was that they didn't agree with that recommendation. So I'm just wondering what your thoughts are around implementation of that recommendation, or failure to do that.
Well, the two recommendations that we made, as you say, and one was to take action to ensure
the update
that the information is accurate. The other is to set up a quality assurance system to make sure of that. There are variations on the same theme, and what we're saying to them is to take some responsibility to ensure that, or take some action, positive actions to ensure that the information you're compiling is accurate, rather than leaving it for us to do later on. The response, I guess, is would appear to be, and certainly in terms of the first recommendation, that yes, they agree it should be accurate, but they're not taking the responsibility to ensure that. Rather, they will work with departments and with us to see to it that it's accurate. Well, we don't work with them on that to ensure it's accurate. That's not our job. And that's not an agreement with our recommendation, which was that they should not continue to do what they're doing now, but to take further action. So in effect, the Treasury Board was saying to us that in both of those responses that they don't feel it's their responsibility to ensure that what the departments and agencies put in there is correct.
So in a larger view is again, we come back to that responsibility issue, is that who's responsible for a lot of these things?
Well, yes, and our view is that we don't care who accepts the responsibility for this, but that whoever is compiling the information and passing it on to Cabinet takes responsibility for passing on accurate information. It's not a question of us telling them that if you're going to compile this, do it right. That's not our business. But if they're going to pass it on to Cabinet, then somebody has to take some responsibility for what is given to Cabinet.
Is there an opportunity for a change in some legislation to ensure that? I mean, again, we're, going on best practice, reasonable issues, but, I think it shows that maybe some of these things still don't get done, even if the best effort of everybody. Should we as a legislature look at a change in the law?
Well, I suppose you could, and I wouldn't rule that out. My feeling is that it shouldn't be necessary to put into law that managers of programs should correct deficiencies that they're aware of in the operations of their programs. So it should be a managerial culture. But there are a lot of ways of accomplishing that, and I suppose that's another one of those ways. I'm not sure how you draft that exactly.
Yeah, no, I just look back at freedom of information. I mean, even though it seemed reasonable and transparent that, information should be released from departments, it took a FOIPOP Act in order to ensure that it was going to be done correctly and within certain timelines. So I'm just thinking out loud mostly that maybe a change to the AG Act might require these things to happen.
Well, yes, it could. I'd hate to, in this case, I guess look at having the AG Act as being coercive and giving us authority to, in fact, enforce recommendations on departments. I think that's probably stepping beyond the bounds of what we should do. Our job is to once we have findings, to report them to this legislature, and then to pass responsibility for taking action on them to the legislature. And I think that's theoretically a more appropriate route to be taking.
Yeah, and I don't think it's the heavy hand of making sure the recommendations are implemented, is at least requiring that the information be updated on a regular basis and for that to be done accurately.
Yes.
If I change over a little bit to the other issues of the day, and I find this one interesting when it comes to addiction services. We sort of ran into this one yesterday in our community services committee meeting when it came to guidelines and the issue of mandatory standards. When it came to the addiction services houses, and we're talking about Talbot House actually yesterday. So I'm just wondering maybe some comments around the issue of mandatory standards and the control of that. I look at more specifically the issue of recommendation 3.2. How are we going to ensure that the standards that are set by the department are actually implemented by the districts and those organizations that offer that service?
Yes, I think, given the topic here, I'll ask Ms. Coleman-Sad to address that for you.
Ms. Coleman-Sad.
Thank you. So specifically with regards to addiction services standards, mean, I think there's some work to be done there in terms of clarifying for district health authorities whether the department considers standards to be mandatory or not, because department staff indicate they feel they're mandatory, but the standards document itself says right on the front cover that they're voluntary. So I think there's some clarification needed there so that, you know, districts understand whether or not they are required to comply with those standards. And then I think going along with that, there's an obligation on the department of the department, on the part, sorry, of the department to monitor, to make sure that those standards are appropriately implemented by district health authorities.
Do you find that the data collection, you know, is adequate when it comes to, you know, the patient files and those kinds of things that are happening on the ground?
I can't speak to specifics of data collection in patient files other than at Annapolis, because that's the only area where we did an audit and specific to addictions files. Mm-hmm. We did do some testing in addictions files. By and large, we found they complied with policies. There was some room for improvement in terms of timely filing of patient assessments and whatnot in the files. Addictions has its own information system, I guess you could call it, called Assist, that's out of the Department of Health. And I know there's some specific information that's gathered in that, but we also found there were a lot of empty fields in that. Some of the fields are not used by all of the districts, and we also identified an error in how the department was calculating the wait times with that system.
Okay. And I think that goes to a greater discussion when it came to the whole issue of electronic medical records when it comes to tracking all of patients. It's not just the specific information on ailments or surgeries and those kinds of things, but there's some data fields I think that we as a province should have an idea about when it comes to wait times or even infection and those kinds of things, so we have a better method to track all patients across the province, regardless if they're in the Valley on addiction services or whether they're in Yarmouth on something else. So I know it's probably more of a general statement than a question, but do you know, again, to the data collection issue, you know, is there a recommendation? I mean, they have their own system. Should there be more of a standard across the province for all these things?
Do you mean for all types of services? Or?
Absolutely, because right now you have an Assist, you have another EMR over here, you have another program for this. You know, it just seems to be an awful lot of data collection that no one seems to have a handle on what's actually going on. Maybe it's a general question for the AG.
I mean, I think that's an area where the Department of Health and Wellness would need to look at that and make their decisions regarding what they feel the data standards are. I don't think that's necessarily for us to say what they should be.
Order, please. Mr. D'Entremont's time has expired. Mr. Wynot.
Thank you very much, Mr. Chair. And I'm going to go back to Chapter 4. My understanding, and from reading the chapter, you did look at CDHA. Is that correct? Okay. So can you comment a little bit about some of the practices in place at Capital Health regarding infection prevention and control that are working well, and maybe compare them a little bit to what's happening in Cape Breton?
Mr. Coleman-Sad?
Yes, certainly. Ask Ms. Coleman-Sad.
Thank you.
So two specific areas at Capital that come to mind are presence of infection control practitioners on units and hand hygiene audits. So we found at Capital Health that the presence of the infection prevention and control practitioners from within Capital Health on the various patient units was quite good. They visit those units regularly.
Okay, so can you just, who are those people? Like, are they just...
They're staff of Capital Health that are involved in infection prevention and control. So it's their role to make sure that, you know, if there's an outbreak, that if a unit sees a higher incidence of some particular disease, then they might get involved to say, okay, is there a concern here? Are we doing everything we should be? And they're just kind of present on the units, making sure, you know, hands are being washed, things are being cleaned, everything is running as it should. And it was very evident when we had our tours of Capital Health that staff on the units recognize those ICPs, know who they are, and realize their role and what they're doing, whereas there wasn't a great presence of infection control practitioners on units at Cape Breton District Health Authority. Another area at Capital Health that we really thought they were doing a good job with was their hand hygiene audits. And I don't remember the exact details from the report, but hand hygiene audits talk about moments for hand hygiene, and there are basically 4. And it relates to kind of before and after patient interaction and times when staff come into direct contact with patients. And so hand hygiene audits measure those moments and measure whether or not hands are being washed at those times. Capital's hand hygiene audits were more detailed. They covered many, many more moments, probably 4 or 5 times as many moments as what Cape Breton's did. They also post the results on the units within the hospital very, very clearly on bulletin boards as we toured around. For example, I noticed many places where hand hygiene audit results and infection rates and whatnot were posted. So they're there for staff to see, which I think helps with awareness, but they're also there for patients and their families to see, because a huge part of infection prevention and control lies with the patient, because the patient has a right to ask a practitioner, have you washed your hands? And if they know they haven't, then please wash them. And so when you increase awareness of hand hygiene and whatnot amongst patients and their families, it helps as well.
Mm-hmm. You spoke about doing a tour of various units and that sort of thing. Are we talking all building, like all Capital District Health facilities? So I'm talking, Musquodoboit Harbour, Cobequid,
No, we toured the VG and HI sites, the Dartmouth General site and Hants. And then in Cape Breton, we toured the regional hospital in Glace Bay.
Okay, thank you. So you talked a little bit about just some examples of CDHA. Would those be simple practices and policies that could be implemented in Cape Breton?
Yes, certainly they would be. I mean, with regards to the hand hygiene audits, it's a matter of doing more of the audits. Cape Breton had far fewer of them. Far fewer of their units had hand hygiene audits. It's a matter of posting the results where it's obvious to people. They post their results on their intranet, I believe, in Cape Breton for staff. It's a lot more obvious when it's sitting on a bulletin board at work every day when you're walking down, and then patients and their families are able to see it as well. So I think increasing the number of audits and increasing the extent of those audits. Cape Breton's audits didn't involve a lot of moments for hand hygiene, a very small number. And the more moments you can cover, then the better a sense of your compliance that you can get.
It's interesting. I recently had to, for a family member, had to be at the Emerge at QE2, and it's actually within the last week since you've released your report, and I actually noticed, I guess probably because I read the report a little bit more, but you actually notice it because you're aware of it. Healthcare workers washing their hands I couldn't believe it actually, how many times they were washing their hands, which I think is a good thing, obviously, but it was, I guess my heightened awareness of that was really good. Was really good. I want to move on to Chapter 6, the Office of the Public Trustee. You note in the chapter that the Public Trustee's Office has a comprehensive policies for managing client investments. Can you just elaborate on that a little bit more?
Yes, thanks. I'll ask Ms. McDonald to give you the details.
Sure.
Ms. McDonald.
Thank you. We found, we wanted to see how and test how client investments were being managed, and we found that their policy covered what we would expect to see. If you look in paragraph 6.29, it details, some circumstances that might be considered when you're looking at a client's investments. For example, their age. So you wouldn't expect to see that somebody who is older is being put in riskier investments. They're looking for stability to meet their needs. Overall, their policies and the way they managed investments, we were pleased with them. We didn't find any deficiencies during our testing.
Okay. Can you comment in more detail on the prudent investor approach used by the office?
I I believe that's what is outlined in paragraph 628 addresses that. So, I mean, we've commented, I think, in the past in this office about the concept of prudent investments, and certainly what's outlined in the Office of Public Trustees policy, as noted there, is just generally speaking to make sure that the risk has been addressed, that you're maintaining capital for the client, and that that the funds are there to meet the client's needs as required by that client's individual circumstances.
Okay, thank you. Your report also notes that staff are following the policies and safeguarding assets when opening and closing estates. Can you comment a little bit more on that as well?
You're referring, I think, to earlier in the chapter, which deals with the opening and the closing. So that's
exactly,
yes. So that's when the staff get the assets, when they obtain the assets from the client, and they set them up in their records at the Office of Public Trustee. We certainly found that for keeping those assets, that and maintaining records of them, that was well done by the Office of Public Trustee. We did identify a deficiency at the time that they become aware, that the office becomes aware that they are going to be responsible for the assets, that the collection process to go to the client's home and pick up the assets, that there was a significant deficiency there, and we've recommended that be improved. When the Office of Public Trustee first becomes aware that they are going to be appointed to look after a client's estates, they will send out individuals to gather the assets, but they don't supervise. The office doesn't supervise that collection process, and we identify that puts the assets and, in fact, even personal information at the client's home in jeopardy. So we've recommended that the public trustee should assign staff to supervise that process to ensure that what they receive from the estate is complete, and that therefore what they enter into their records is complete.
And would that be existing staff that the office already holds, or do you think that could that be done in the capacity of existing staff, or would they have to hire more?
I think that decision is up to the public trustee. They are undertaking a risk assessment right now, and I know that they're looking. Mr. Lapointe made reference to a meeting that we held with them, and I know that they are looking at some alternatives, but ultimately the decision as to whether or not they hire more staff to implement that recommendation is their decision. Certainly, though, we think that there's enough of a risk there that they need to address it.
Okay. I'm interested in around the whole question of providing guidance to staff making healthcare decisions for some of the clients. Can you elaborate on that policy a little bit more? I'm just interested in that.
Certainly. The healthcare decision aspect of the public trustees' mandate my understanding is that it's been somewhat informal, but that it's been more formalized lately through legislation, I believe in 2009, and that it finally came to be that the public trustee office set up a division to deal with these decisions. So we tested a few things. We wanted to see that the policies that they had developed were in line with the legislation. So, a policy that says, for example, that there's certain paperwork that has to be associated with the public trustee having the jurisdiction to make these decisions, that policy addressed, here is the paperwork that you need to see. We also wanted to see that there was, support for the decisions that the healthcare decision group ultimately made. And we were satisfied that through our testing, we found, no serious deficiencies and 3 minor deficiencies, which are identified on page 139 with respect to the decisions made. So overall, the healthcare decisions and that division within the Office of Public Trustee was operating well. So
you mentioned about testing. Now, I wanted to ask, I forgot to ask this question earlier, but how do you test that? So are you, do you just look at what has happened in the past, or do you, how do you test that actual, those policies? Like, just walk me through what exactly happens.
Sure. Well, there's sort of two phases. First, there's the policies themselves. So we're looking to see that the way the policy is written, and perhaps any procedural aspects of the policy, that they address the legislation. So, as I mentioned, here's the legislation. Here's what papers should be in place per the legislation before the public trustee has jurisdiction. So how does the policy reflect the legislation? And we were satisfied that the policies were well developed and that they reflected the legislation. Then with respect to actual testing of the policies in place, we pick a sample, and the sample extent that we use is based on audit methodology and probably beyond this conversation. But we then select individual client files, and we look to see that what is in the file in terms of documentation is supported by what the policy said should be in the file. So again, my example of jurisdiction, so that the paperwork that should accompany whether or not the public trustee has jurisdiction to make a health care decision is in that file. So that's basically our testing, and as I indicated, we were satisfied with our testing.
Great, thank you. Mr. Chair, I'm going to pass this over to Mr. Burrell for the last few minutes.
Mr. Burrell?
Thank you, Mr. Chair. Just following along these questions about the Office of the Public Trustee, I was just wanting to get a clarification about the final section of your report dealing with the matter of the inadequacies in financial reporting. It's not immediately apparent to a non-specialist from the report exactly what it is that is lacking in the present system. Am I right in taking the understanding from the report that the current system would allow a client or those acting for a client to review adequately what was being done on the client's behalf through the Office of the Public Trustee, that part was okay, but that in aggregate, taking all this together, there was an inadequate system for determining how the whole office was doing for the community of clients? Is that the point that's being made?
Mr. Lapointe?
I think I can shed some light on that. It's actually a pretty simple point. That looking at it now more from the point of view of their financial auditors, which we also are. When Ann's group was in there, we found that in fact they keep track of all their financial operations, which any organization does, through systems that have developed over the years and focused on keeping track of client assets. But they, like any standard organization, have revenues and expenditures, have balance sheet income statements, and don't have an accounting system to track all this. So when we first run into this on a practical basis is when we come to review their financial statements at the year end, assign an opinion on it. We find that, of course, they have a lot of difficulty taking the records that they have, which were developed for other purposes, and extracting from that the financial information they need to produce a financial statement. They manage it, but for instance, right now, Ann will correct me if I'm wrong, but I believe they have one person on staff who I could say really understands how they do this, to go from, in effect, a tracking inventory system to an accounting system, and to get the debits and credits you need to produce an income statement. That person can do it, has a very difficult time. Our staff can understand it as well, but not only is it very time-consuming, it's not meant for that purpose. So it's really a simple matter of not having a standard accounting system that any operation of this size would have in place to do that, and that's because it's evolved in a different direction.
Order, please. Your time has expired. Mr. D'Entremont, you had requested some written information. Were you satisfied with the answer, or do you want the written information? And if you do, could you explain exactly what you're looking for?
No, I'm satisfied with the answer that I got.
Great.
Yep.
Thank you. With that, I'd ask Mr. Lapointe to do any wrap-up comments you would like to have.
Well, thank you, Mr. Chair. And in closing, I'll just say that I've appreciated the opportunity to discuss my report with you today, and my staff have as well. And my staff and I do appreciate this committee's continuing commitment to strong accountability in Nova Scotia. Thank you.
Thank you very much, and thank you again for your report and comments today. And we had, with some information supplied to the members that's on your agenda sheet today, and the clerk informs me that all that information has been supplied. Our next meeting will be later this fall, to be determined by myself and the subcommittee. And unless there's any other business from the committee, a motion to adjourn would be in order. It's been so moved, we stand adjourned, and I would just say everybody enjoy your summer. Thank you.